thrilled to see you all here today and excited to hang out for the next hour to nerd out. Charmaine is on her way and will be here soon for us to tag team on today's case. So as always, we would love somebody to present a case so we can all learn together. And for two folks, ooh, Colleen, amazing. All righty, perfect. Colleen, we'll have you reintroduce yourself in a moment. Yeah, I think it is in record time. Would love for two volunteers to discuss Colleen's case with Charmaine and I. But in the meantime, we have yesterday's esteemed discussant here to reflect on the medical learning we had yesterday. So Kirtan, the mic is yours, my friend.
Yes, hello, good morning, everyone. I hope all of you are doing well. So yesterday we had a very amazing case. So Zevan was kind enough to present that case to us. And it was a case of a gentleman who presented with tremors and myoclonus, and he had chronic kidney disease. So initially our thoughts were like, okay, the patient has chronic kidney disease, the patient has creatinine of 6.6, the patient has BUN of 96, all of them were off the charts. So maybe the patient has uremic encephalopathy, and we know that uremia can cause neuromuscular irritability, and that can explain the tremor and myoclonus. But then Zevan and Steph both taught us amazing pearl that what's the baseline of the patient. I mean, the patient had creatinine of 6 since ever, which means that if creatinine was indeed responsible, then why not patient developed it earlier, and why now? Same was true for calcium also. The patient's calcium was around 7, but it had been 7 and 8 since ever. So why calcium can cause all those things? Furthermore, if uremia was to explain everything, then the patient should have evidence of encephalopathy. The patient was alert and oriented to time, place, and person. So if indeed uremia was the factor, then it can't explain the tremor and myoclonus. And then we get evidence of the fact that patient was prescribed fluoroquinolones recently, to be precise, levofloxacin. And then I just realized that one of our global VMRs, in which we did 3 cases simultaneously, it was only one special VMR. And in that, the first case was presented by our dear Maria. And Maria mentioned that cefepime encephalopathy and how it can present with seizures and everything. And in the teaching points of that case, both Maria and Gabriela mentioned that apart from cefepime, fluoroquinolone groups of antibiotics are notorious for causing this. So I was fortunate that while reading the case yesterday, while discussing, it just hit me that, yeah, this seems very similar to what Maria discussed that day. So I mentioned that maybe fluoroquinolone can do this. And then later on, Anne Mary mentioned that we have to be careful of the fact that although we prescribe levofloxacin once every 2 days, but what if the patient misunderstood it? And what if patient is taking it twice per day? And the fact that patient has renal failure can further compound the problem because you won't be able to renally clear it. So it was indeed a case of fluoroquinolone-induced encephalopathy causing tremors and myoclonus. So it was an amazing case. I learned a lot from it and realized that uremia is not answer to everything. We have to understand the baseline of the patient and always worry about the iatrogenesis. So thank you so much for that.
That's an absolutely brilliant recap, reminding us that abnormal may be in fact normal for the case today, and that abnormal creatinine is actually expected in that patient. And then what a great way of emphasizing how we all learn. You know, you hear something someday and then it comes up another day. And when you hear something from a fellow CP Solvers team member, it makes it extra special. Thank you so much for that incredible recap. And I will say that it is actually really good timing to practice this stuff because the neurology virtual morning report case that was just released on the podcast is a similar case in that is an abnormal movement. It's a different kind of abnormal movement. And you'll hear some very familiar voices on that podcast that you may or may not have either heard or mentioned today. So I would highly, highly recommend you check that out for space learning of a similar kind. I see another familiar face on here. Charmaine, hello. You want to say hi?
Oh, well, hi, team. So good to see everyone. What's up? What are we up to today, Robbie?
We are in for a special treat because Colleen is presenting a case and Nilayan has jumped into the lukewarm seat to discuss it with us. And we're still looking for one more discussant. But in the meantime, maybe Colleen, you can unmute and tell us, remind the VMR community of who you are and where you're calling from.
Hey, I'm Colleen. I'm a 4th year med student at UCSF. Just finished a couple months on the wards, did my medicine rotation at the VA. Saw Robbie there. And just did some infectious disease last month.
Oh, nice. Where'd you do ID?
At Parnassus at the main CSF
cool.
hospital.
That's awesome. That sounds so exciting. You have like a very massive painting, or I don't know if I can't tell if that's a carpet or something. What is that?
Made out of fabric, yeah. It's I bought it at a thrift store. I don't know that much about it.
It looks gorgeous though.
Thanks.
Really, really pretty. Only rivaled by Nalayan's very pristine white background. Hello, my friend. Do you want to say hi?
Sure. Hello, everyone. My name is Nilayan. I'm a fourth year med student from New Delhi, India, and really excited to be here. And what can I say? It's 8:30 at night here, so I'm excited.
Tell us a little bit, any updates on how things are in India from the COVID perspective. How are things in New Delhi?
Oh yeah, things are improving. We are opening up, but we are also being careful because the Delta variant is here, and we are nowhere near what we should be with respect to vaccination rates. And it is expected that the Delta wave will hit us in 6 to 8 weeks. So our colleges haven't opened up in anticipation that if the Delta wave comes in and then they again have to close up, and then it's just a waste of time. So we are having online classes, which sucks in medical school because most of the things are supposed to be hands-on. But yeah, so this VMR community is a big save for me. It gives me the mental stimulation that one gets from wards. I miss the patient interaction and the hands-on skill, but yeah, it's the best I can have, and I'm really privileged to be here.
Oh, of course, the privilege is all ours, my friend. Oh my God, look what you just did. You inspired a fellow VMR veteran, I would say. Hans, do you want to say hi?
Yeah, good morning. I dare to discuss one more time, but you guys are way better than I am. So I'm a clinical facilitator at Ross, hoping to match.
Incredible, my friend. I would say better is very subjective. It's like asking you what is better, blue or green? There
I
is
don't
no
know.
better than blue or green. It's totally. Oh, well, Maria has strong opinions. Thank you for supporting my point, Maria, and not completely botching it. I completely. You know what? I wish you 40 more step 2 or step 1 questions. Hans, it's a delight to have you here, and we're so excited to discuss the case with you. I'll hand the mic to Colleen to kickstart the case, and for Charmaine to jump into the first aliquot.
Hang on a second, sorry. Okay, so this case is a 64-year-old woman presenting with a chief complaint of fever and rash. You want me to do the HPI?
We can already discuss this one.
Ooh, I think we lost Charmaine. I'm so sorry. Unless folks see her here, narrow connection probably. I lost, but maybe Hans and you and Charmaine can work together, and I'll kickstart it by passing the mic to you to see what your thoughts are with this data.
And my first thought would be, and I think everybody agrees with that one, it could be an infection, either parasitic, tick-borne, or otherwise, which caused a fever and a rash. So if, for instance, in the HPI, it tells us she likes being outdoors, gardening, etc., it could be Rocky Mountain fever, something like this. It could be a malignancy that shows a paraneoplastic disorder. There could be a rash, maybe not necessarily the fever. Then vasculitis, I don't think so. Not at this stage, I don't. So I hand the mic over to somebody else.
Oh, my friend, I don't know if the mic needs any more words in it. I think I agree with you. I think you've listed some very important broad categories: infections, autoimmune disease, drugs, and then mentioned one infection that's present everywhere in the world. One interesting thing about Rocky Mountain spotted fever is it is very geographically restricted. It is only present in the United States in some areas, but rickettsial diseases, which is the broader term, are present everywhere in the world. So no matter where this patient is, we have to think about it. But I will say there's one really important thing here. And that has to go with what the patient is saying is a chief concern. Picture this. Imagine if your patient has many other organs involved. So imagine if she might have a headache, might have dyspnea, might have abdominal pain, might have joint pain. The fact that she is choosing to emphasize the rash is very telling, which is why I would tell you to pay a lot of attention to what the chief concern. The first words out of the patient's mouth are incredibly educational because they tell you what the relative peaks are of each individual complaint. And I will tell you, if somebody has a debilitating headache, shortness of breath, abdominal pain, or extremity pain, they're unlikely to mention the rash. Think of if you've had a really bad sore throat and your rash is mild, what are you going to tell your provider? You're probably going to tell them that the sore throat is bothering you. So what does it do to the landscape if the rash is so prominent that it becomes part of the chief concern? It makes me wonder whether the skin is the center of gravity of this disease, whether the amount of visceral involvement is rare, is not the amount of visceral involvement is minimal or less prominent than the rash. And that's when one category becomes predominant. Drug-induced skin inflammation is almost always just restricted to the skin with the exception of dress. So for me, fever and rash has an extensive differential diagnosis, includes necrotizing fasciitis, includes T-cell lymphoma, B-cell lymphoma. It includes a whole variety of autoimmune diseases like vasculitis. But if the rash is in the chief concern, it tells me that the center of gravity is probably in the skin, which for me prioritize drug-induced causes over everything else. But you have to be open to the possibility that the patients may be too altered to give you an appropriate prioritization of things. But if rash isn't the chief concern, I would worry that the skin is the predominant disease involved, which would prioritize a drug in the eye-made mnemonic: malignancy, autoimmune, drugs, and endocrinopathy, with eye being, of course, the infection that we always have to entertain. So with that, I'll pass the mic back to Colleen for more information.
Okay, so her presentation started about 1 month prior to when she came to the hospital. She notes that while she was gardening, she got a cut on the bottom of her right foot and subsequently developed tenderness and erythema of her lateral right foot and was diagnosed with cellulitis. She was treated with 2 weeks of Keflex without improvement, and then was started on minocycline for 30 days, which she took about 2 weeks of that for presumed cellulitis. Then over a period of about 3 days before her presentation, she developed like a bigger constellation of symptoms that started with, she developed some worsening tenderness and erythema over her right and left great toes. Then developed a distinct rash from her presumed cellulitis, starting on her back, which then progressed to her lower legs. And then finally, the day of her presentation, woke up, took her temperature at home and had a fever of 101.5, also with some neck stiffness, upper back pain, and bilateral eye redness.
Is this a good place to stop, Colleen?
Yeah, I think so.
All right. Wow, what a rich case so far. And also, by the way, my computer couldn't handle the awesomeness of the VMR and completely crashed for a good few minutes. So I'm glad to be back. My friend Anilian, what are your thoughts on the rest of the information that we've gotten so far?
Yeah, before I start, what is with me and rashes? The last time I discussed, I got an nodulo-ulcerative rash with medial versus, and this time I have a rash. So, all right, I'll start. So the patient had a cut while gardening. So the first thought that crossed my mind was porotrix, because that has a typical association with a cut that ascends in a lymphatic pattern, but the patient has nothing like that. So I'll keep that thought aside. Uh, Moving forward, the patient has tenderness and erythema, which is indicative of cellulitis, which is somewhat expected because the bacteria or the agent has an entry portal, and the bacteria is now infecting the skin. So, all right, cellulitis is expected here. And she was treated with antibiotic for 30 days, all right. And 3 days from now, she has a developing rash. So I had three theories for this rash. A, we treated the bacteria, the initially infecting organism, but we didn't treat it properly. Maybe we got the drug wrong or the bug wrong, or we didn't have a source control. And that bacteria has now metastasized to multiple areas. Something like neck stiffness can be interpreted as meningitis, or upper back pain could be something like an abscess or vertebral abscess. Eye pain could be uveitis. So theory number one, it's a bacteria that has metastasized to multiple areas. Theory number two, it is a drug reaction. So the drug we gave, the bacteria and the drug are maybe forming immune complexes, and now we're having a vasculitis, the secondary to deposition of immune complexes. So a medium or a small vessel vasculitis in that sense. A third condition, that the infection kicked up an autoimmune process. The patient might have been susceptible to an immune process, something like SLE, not saying SLE, but something like SLE, something like APDA. And the infection has now just kick-started that process, and the patient is having those manifestations. Having said that, the fever of 1.1 or 1.5 so fast makes me prioritize infections over other etiologies. And neck stiffness, again, meningitis, or could be aseptic meningitis. I think you presented a case with aseptic meningitis, and that just opened my eyes. And upper back pain, again, I'm interpreting in terms of vertebral abscess. Could be other etiologies, but not very sure. Eye redness bilaterally. Now, redness of eye can have multiple etiologies, right from conjunctiva to uveitis. Okay, maybe I had one more in mind and I forgot. But yeah, which could be again infective or autoimmune. So right now, I'm not very sure how to localize it, but keeping infections over other etiologies. Those are my thoughts.
Those were some brilliant thoughts, my friend. That was fantastic. You taught us so much. So I'm just going to summarize basically what you've taught us. And what I really, really love, like using the antibiotics failure schema of like, hey, this person came in with this presumed cellulitis and it failed to get better. One thing that I also noted was that like, it's been going on for a while, right? So something that has been brewing there, something. So the question is like, is this more of an indolent presentation that now has spread? Is this something that was happening in the background and then got another infection, or something is now exacerbating that as well? So are we dealing with one process that started, or are we dealing with two different processes that is complicating this? Is something that came to my mind. But I love the antibiotic failure schema, thinking about like, hey, were we in the right track with the diagnosis and we just didn't give the right antibiotics? Is this because this is a rare cause of cellulitis, not our usual like staph and strep species that we treat, and now it has like metastasized, and that it was the foci of infection that now has spread to the rest of the body? Or did we just have the wrong diagnosis? I hope at some point Robbie shares his cellulitis mimicker schema, which is one of my favorite things. That we think about cellulitis like, you know, usually we see it red, we treat it, but there are other etiologies that can mimic it, anything from like autoimmune, anything from malignancy. Like a gout can have a sub-acute infection, like a sub-acute presentation as well. So a lot of things, as you mentioned, in play, and it's totally fair to be like, hey, I am still worried most about an infection, because at the end of the day, that's something that we can treat, that's something we can localize. And the fact that this patient over the last few years has more systemic signs, it's concerning, especially as you mentioned, you know, with the neck stiffness, we worry about now, is it a spread to CSF with back? I love, love that you saw that a back pain and immediately thought like, hey, if I'm worried about a metastatic infection. Is that also now an epidural abscess that I need to worry about? So I'm right there with you. I think, especially with the eye finding as well. I think with the eye finding, depending if it's a conjunctivitis, scleritis, if it's sparing, the pupils are sparing or not, then it would give us a lot of helpful information, and a lot of time it could clue to like what type of infection we're or autoimmune disease we're concerned about. So right there with you, I think in terms of prioritizing infection for now, getting like blood cultures, doing a good physical exam, some imaging, and again getting a better understanding of the background of this patient to put this presentation into correct context. Brilliant job, friend. I like literally had nothing to add. I just summarized what you taught me.
Can I actually, I forgot like kind of 2 points I should have added to her HPI before we move on. So just 2 kind of relevant points is that the patient reported having a URI about 2 weeks prior, and also had a recent outbreak of oral herpes that she treated with acyclovir. Okay, anyway, moving on. So for her past medical history, she's like I said, a history of oral herpes. She has rosacea, a history of Raynaud's syndrome, hypothyroidism, migraines, chronic back pain, secondary to scoliosis that she's had her whole life, and obstructive sleep apnea. For her medications, she takes the minocycline, levothyroxine, gabapentin for back pain, valacyclovir as needed, sumatriptan, and then for her rosacea, she uses a topical retin A and topical metronidazole. For her, like no contributory family history. For her social history, she lives in a house in the Central Valley of California. She has never really worked. She has 2 children and watches her grandchildren most of the time. No exposure to wooded areas, although she is a frequent gardener, and no major animal exposures. For her health-related behaviors, she has a remote smoking history, no alcohol, no illicit drugs, and is not sexually active. And then no allergies. Okay. So for her vitals, she presented with a temperature of 38.3. Her heart rate was 112. Blood pressure was 145/71, satting 97% on room air. So this woman, she was for general, she was a thin, older woman, comfortably sitting up in the gurney, no acute distress. For HEENT, she had non-purulent conjunctivitis of both eyes. Her oropharynx was clear. On her neck exam, she did have some minor neck stiffness, but no Kernig or Brzezinski sign. She was able to move her neck. Cardiopulmonary exam was normal. Abdominal exam was normal. For her neuro exam, her cranial nerves were intact. She had normal strength and sensation. throughout. And then we did I think a pretty thorough joint and skin exam. So on her joints, she had bilateral swelling and erythema of both of her MTP joints with normal range of motion, also with bilateral knee swelling. And for her skin exam, she had erythema of the right lateral foot, also over her first MTP joint, and bilateral Achilles tendons. And then had this other rash that was like scattered pustules or papules with an erythematous base on her arms, legs, and hands, sparing her palms, also on her chest, neck, and face. I think I can drop an image of this into the chat. Can I?
Amazing. You know, since there's so much to discuss, we can take a look at the image in a second. Hans, you're gonna have a lot of work to do. We got so much information, and maybe we can try to digest it slowly, like a 3-course meal, maybe. How about the medical history? How about the additional data we got, which is that we learned that the patient has had a URI and then also has herpes infections. Anything that crosses your mind when you hear that?
Yes, it was already mentioned in the chat. Herpes infection could come together with erythema multiforme, but that doesn't look like erythema multiforme the way it's described in the skin exam. Then we have probably the possibility of some drug-induced rashes like the DRESS syndrome. That has been mentioned as well. And looking at her work in the garden and living in California, I'm kind of inclined to think maybe she has some sun sensitivity secondary to one of those drugs that she's taking, like minocycline can sometimes cause this. But then again, her rash is mainly on the lower extremities, and we need to explain her swelling of the joints, which looks a little bit like SLE, but again, it just doesn't fit the whole picture.
I
So
agree. Yeah. Oh, sorry. Go ahead, please.
So I'm really inclined to think about, yes, something with vasculitis, serology, autoimmune that could have caused all this. Maybe even a fungus. I'm just wondering whether coccidiomycosis, cocci is quite endemic in this area. Central Valley, that's where it is home. But it's usually you get infected through your lungs and not by an injury, and it doesn't cause a rash, to my knowledge, but I might be wrong here.
There's a lot. Yeah. It sounds like you're worried about autoimmune and infection, and I think that that's so telling. I think I love your phrase, the Central Valley is Cocci's home. I think that you really have to prioritize coccidiomycosis anytime somebody has an arthritic syndrome with rash. And in fact, you know, the original name for cocci was actually desert rheumatism. It's a interesting play on the fact that from the desert in the Central Valley would these mysterious autoimmune diseases with erythema nodosum, arthralgias, and a nondescript systemic inflammation would emerge. So is this desert rheumatism? Maybe. But I also love how you jumped from a history of HSV to the connection that there might be erythema multiforme, but rapidly dismissed that because the rash is less consistent with it. And I'm trying to look to see like if there's any other history in the medical history that's pertinent, and nothing is crossing my mind with the exception of the prior URI. And odds are that many people have had URIs prior to anything happening to them. But if you're trying to connect URI syndromes to systemic inflammation, it's hard not to wonder about the possibility, if this were a patient not in the United States, rheumatic fever would cross your mind. You have a patient who has had a pharyngitis syndrome who presents with arthritis and a rash. And again, the appearance of rheumatic fever rash is very different than the pustule rash we have now. And I think it's wise to drop our anchor in the fact that there are pustules everywhere. So any thoughts that begets, Hans? Like when you think of a patient has pustules, does that guide you in any way, shape, or form?
Now I need some teaching points from somebody else.
Of course.
Pustules are very characteristic of something,
Yeah.
and papules. So that could be related to a drug causing these kind of blistery skin eruptions. So it's a vasculitis, autoimmune, more like a drug reaction. I don't know what the others can guide me there.
I think Robbie might have frozen. Oh, yeah, Hans, I think you're absolutely right to think about the drug reactions. I think AGEP is the one that comes to mind with, especially with the pustules, and usually with the time frame that it could fit possibly as well. So that is a good thought in addition to infections that you mentioned. Yeah. And I see Kushal, the one and only, says that cocci can cause pustules as well. Usually not. I've actually never seen that, so that's actually great learning as well, and a great point about it can enter through the wounds too. Anything else about the exam that jumps out to you, Hans?
I'm also looking at the non-purulent conjunctivitis, which is looks like a non-bacterial injected conjunctivitis. That could be viral. It could be, again, something like an allergy, autoimmune, maybe fungal. We were just discussing in the chat that cocci can enter through puncture wounds as well. It doesn't have to be the lung. So we are still open for almost everything here.
Yeah, I 100% agree with you. And before we talked about the conjunctivitis, Anne Marie, my friend, I love, love, love your list of pustules. Do you want to share it with the rest of us?
Just thinking generally about pustules, some of the things I'm thinking of are a disseminated gonorrhea infection. Wasn't sexually active here, but always something to think about. Pustular psoriasis, AGEP, which can happen after antibiotics. Usually they're really small pustules on a very erythematous base, and then like things like staph infection, things like that. Just to name a few. I'm sure the list is very extensive.
Yeah, no, those are fantastic, fantastic thoughts. And yeah, absolutely, like strep folliculitis is the one that I wasn't thinking about. So thank you for reminding us of that as well. That sounds, and in terms of like the conjunctivitis, absolutely, like a lot of like the viral infections, autoimmune, can also cause like conjunctivitis. It doesn't in this case helps narrow my differential as well. You know, I think the sparing one, we sometimes talk about like lepto, again, not the classic risk factors that I would think about for this patient, but I think the differential remains broad. I think the fact that there's no mucosal involvement is actually, that's the one that I was looking for on the exam to make sure we're not dealing with a drug reaction. However, I think whenever the antibiotics are at play, I think drug reactions should stay on our differential, especially with the pustules that are forming while we investigate any other and any other point of entry for any infection. I completely missed the gardening part on the HPI, and I was like, oh, why are people talking about gardening? I'm like, oh, I didn't see it. So I think that as a portal of entry, as everyone has mentioned previously, the infections that you think about, like also Nocardia, fungi, and still come to play. So any other thoughts from you, Hans, or Niloyan from the exam before we move on?
No, I think the chat has been brilliant in putting up differentials that I didn't even know existed. So yeah, and no thoughts from.
Wait, RG is back. Why are you staying quiet? Jump in. Bye.
I had much rather learn. No, I love this. I don't think I have anything to add. I'd say that that really, I think answering why there are pustules is a great line of thinking to go, and I love Anne Marie's differential diagnosis. I think the arthritis is also such a the presumed arthritis is an interesting thing, and whenever you hear pustular rash and arthritis, I think after you've thought of the scary infectious stuff that Anne Marie so thoughtfully listed, I think reactive arthritis is something that jumps to mind too. You know, a post-URI syndrome that has joint, eye, and skin features is another consideration. But I agree. I think it's hard not to drop our anchor there. And I will say, at the end of the day, we know there's some sort of inflammatory trigger here. And whenever somebody's been on a medication for 30 days, you have to wonder, is there a medication-induced inflammatory trigger? And the reason it's jumping out to me is this is a story from my days as a second-year medical student, when the first ever case report that I wrote up kind of began this journey, quite honestly, was a case of somebody who had autoimmune hepatitis from minocycline. And minocycline is one of the two drugs that is notorious for triggering autoimmunity. Long story short, that case never really got published, but I got to present it at a annual society meeting, which is the most nervous I've ever been. And so here is that anxiety now actually being helpful, because because of how nervous I was, I don't think I'll ever forget it. So seeing minocycline in red here and having the patient have autoimmunity makes me wonder, is minocycline implicated in some way, shape, or form? But yeah, I think pustules are hard to ignore, and hopefully Colleen will give us more information to study them more closely, including the context in which they've developed.
Okay. Sorry, I was trying to bring a picture in, but I'm having a hard time. I guess you'll just have to believe me that they're pustules. Okay, so for labs, on presentation, she had a white count of 16, hemoglobin of 13.6, platelets 275. I don't have the diff up, but this was a neutrophil predominance with normal EOs. Then for her chem panel, her sodium was 134, K 3.6, chloride 99, bicarb 23, UN 10, creatinine 0.52, and a glucose of 125. I don't have her divalence here. LFTs, I'll just tell you they're all within normal limits. She also had an ESR and CRP. Her ESR was 65 and CRP was 276. She had blood cultures that were negative. And then an LP that showed a glucose of 80, protein 36 with 1 white blood cell and 1 red blood cell. And then I was gonna put, there's like a bunch of kind of more specialty labs. I was gonna put my 4th aliquot. I don't know if you want me to stop there.
Since it's about 50 minutes to the hour, do you want to just give us those lab and the 4 of us can go into it?
All right, so she had some infectious disease labs. So her HIV was negative. She had gonorrhea and chlamydia, pharyngeal swabs and skin swabs that were both negative. She had a HSV1 and 2 skin swab and CSF PCR that were negative. Negative VZV swabs. She had an adenovirus test that was negative, and then the COXY, complement fixation, and immunodiffusion were both negative. She had a negative ANA and ANCA. She also had a peripheral smear that was normal. And then a CT, brain, neck, chest, and spine that were negative for acute findings.
Colleen, I love this case.
There's a lot of stuff in it.
Is this a good place to stop now?
Yeah, the last one is the reveals the diagnosis.
Okay, great. My friend, what are your thoughts about the labs?
Yeah, I'll go on. Before I start with the labs, I had a thought previously that in the face of rosacea, Raynaud's, and hypothyroidism, I wonder if the Raynaud's was primary or secondary because the patient is already hypothyroid. So maybe it was secondary to Hashimoto's and the patient had Raynaud's, but the scleroderma component was not revealed then. In the face of rosacea, scleroderma could be a viable diagnosis. Just saying, I had that thought previously, but now coming to labs, I also had this thought that maybe the patient was an acyclovir, right? And an acyclovir is notorious for causing bone marrow suppression. But seeing the WBCs and the RBCs and the platelets, I'm somewhat reassured that the patient is not immunocompromised in that sense. Having said that, sodium is 134, which is slightly low, and so is the potassium. Potassium is actually, I think the lower limit is 3.5, so just maybe borderline. I don't know what her usual potassium is, but I was thinking more in terms of acute interstitial nephritis, maybe causing a wasting, but I am not sure what the calcium is. The glucose also seems okay, so maybe not. We have other etiologies of hyponatremia, so I leave it to that. And blood cultures are negative. Is the CSF protein of 36 normal? I'm not very sure on that. Wait,
Can
I'll go on.
you repeat that one more time? Sorry, I didn't catch that.
Oh yeah, sure. Is the CSF protein of 36 normal? Oh, all right. So CSF is unremarkable, which is surprising because the patient did have a back pain, which I thought to be a meningitis sort of picture. And also the negative spinal scan, because I thought that could be secondary to abscess. But a pain in the back with no anatomical defects makes me think of neuropathy. But I think we had a case whereby we had a back pain, and Jack shared a really interesting point where he said, if the back pain is in midline, then think of bone. But if it's paraspinal, then maybe think of muscles and the nerves. So it might benefit us to know where the back pain was localized to. But in the face of the fact that the scan is negative, maybe neuropathy could be a viable differential here, and something we had to keep in mind. Most of the viral panels were negative, but I had this interesting thought: what if the viral panels are too high, something like a prozone effect, and we are getting a false negative? I thought that maybe for ANA, and I don't know if ANA negative, we can still have SLE with ANA negative. If it's false positive, then maybe it's a prozone effect, and we have a very high ANA positivity here. But in a 64-year-old female to be diagnosed with SLE sounds a bit odd. It's possible. It's VMR, and the peripheral smear is normal. That I'm not very sure on that. Apart from that, CT brain is normal. Again, surprising because I thought maybe we could have seen some evidence of inflammation, maybe some dural thickening, something to suggest of meningitis. Maybe an MRI would help there. But the fact that the tap was negative again makes meningitis less likely, and I'm lost so as to look for a cause of what caused her back pain. So yeah, that's where I'm at.
Yeah, I love how you walk through all very systematically and inclination of wanting me to explain the labs. And that is like such great practice. I really admire that you do that. And this is tough, right? So this is a person who's coming in with very impressive presentation, right? Inflamed, rash, conjunctivitis, pustules, febrile, leukocytosis, and then elevated inflammatory markers and nothing else. And then the question becomes, why? What happened? So I think your inclination thinking about like, is there a test that is falsely negative? And with a lot of infections, again, like, with the windows, is a really, really good, good practice to have. Again, like, I think the question becomes like, when did that more fulminant infection, if we're calling it an infection, let's assume it is, started. If it was like 30 days ago, a lot of the serologies would probably be positive unless like it got cleared. Or is it something that the patient got in more acutely, and then some of these serologies might be falsely negative? And that is something that I personally have to look over at as our infectious disease colleague. But I think if you're clinically having have the inkling that like, hey, I'm still worried about this. I'm worried that like all of these negative tests, I still have like a clinical suspicion for cocci, for example, then investigating that a little bit further makes a lot of sense to me. The fact that the CSF is fluid is normal, that's reassuring. We don't have to think a little bit more. However, a lot of the time with CSF, again, like your troponins, sometimes you just need to trend them. So if the patient becomes more symptomatic, you might not be catching the pathology right there. So although reassuring for now, again, as patients hospital course evolves, then that could evolve as well. I think in terms of like, what would I do the next step? I think the rash still, we have to explain the pustules and getting derm involved. I think then the question is like, is this something that we just like are not catching in the blood and is hiding in the tissue? So a biopsy of some sort would be helpful. As where my mind is going, I still would want to rule out an infectious etiology before thinking about more like, as Robbie mentioned, is this a case of a reactive arthritis? I'm not as worried about like, the drug reactions like this. We don't have, the classic like liver involvement, the labs for that. I'm still gonna want to rule out infection more than anything else. I don't know, Hans, Robbie, what are your guys' thoughts?
Hans, where are you at?
I'm still here, yes. The best thing that came to my mind is just to look at the pustules themselves and do a biopsy. But even if I think about an autoimmune or an immune reaction caused by the drugs, I can't explain the neutrophil predominant differential, which makes us think about an infection bacterial rather than autoimmune or immune complexes. So maybe have a look at the pustules.
Hans, unfortunately, I have to recuse myself from the rest of this conversation because I just remembered that Colleen had emailed me about this case and it suddenly just clicked. So I'm not sure that I can authentically reason because I'm privy to the final answer, though it completely escaped me until maybe like a few minutes ago. And so all I will say is I think that the instinct of everybody here is so incredible, and knowing the answer before everybody else does is just, it gives me the first insight I've ever really had into the VMR about what it's like to be the case presenter. I haven't presented a case. And I imagine Colleen is feeling this too, of just how incredible your reasoning is and how you're zeroing in on it. And I'll pass the mic to Nilan and Charmaine to see if they have any final thoughts before Colleen tells us what's going on. I'll tell you, you're in for a very, very fun case conclusion that I will reveal.
Colleen, teach us. Nilan, any other thoughts?
Okay. No one else? Okay. All right. Well, you all wanted a skin biopsy. So that was the next thing that we did. So she had a skin biopsy that had a negative gram stain, KOH, and AFB for organisms. That was also culture negative. And then on PATH revealed a neutrophilic dermatitis with neutrophil infiltrates within the superficial dermis, which are findings consistent with Sweet syndrome. Which was a diagnosis that I had never seen before.
What? Oh my gosh. Wow, it makes sense. And it completely, I didn't think about Sweet syndrome. What a fantastic case. RG, you were absolutely right. Colleen, do you want to teach us a little bit about it?
Sure. So Sweet syndrome is like a very good infectious mimicker. So kind of a more descriptive name of Sweet syndrome is acute febrile neutrophilic dermatosis. And clinically presents as abrupt onset, usually painful erythematous plaques or nodules, or in this case, can be more pustular, along with fever and other signs of systemic inflammation. Patients often have an elevated white blood cell count, elevated ESR and CRP. And in terms of what causes this, so Sweet syndrome is kind of like the path diagnosis of it. And within that, there are kind of three buckets that can cause Sweet syndrome. So there's classical Sweet syndrome, or also called idiopathic Sweet syndrome, which is often associated with URI or GI infections, and usually presents within a couple of weeks of those. So for this patient, her having had a URI 2 weeks prior kind of helps her fit into the criteria of classical Sweet syndrome. There's also drug-associated Sweet syndrome, where this rash and fever develops with the temporal association with a number of different drugs. The most common one is GCSF or other kind of bone marrow stimulating medications, but is also associated with a number of different antibiotics, minocycline being kind of the biggest offender. So it's also possible that this patient had drug-associated Sweet syndrome. And the third bucket of Sweet syndrome is malignancy-associated Sweet syndrome, where people can develop this constellation of symptoms. And it's usually associated with hematologic malignancies. And if you go on UpToDate, there are like more specific dermatological society diagnostic criteria for Sweet syndrome. We kind of went over all of the symptoms, but one of the main ones is response to steroids. So usually when you put these patients on oral steroids, they improve really quickly, which was the case for the patient that I saw.
Colleen, that was fantastic. Thank you so much for presenting this case. I struggled through it, and I'm very happy because I learned a lot. And Sweet syndrome, I'm gonna add it to the list of things that keeps fooling me, but hopefully this one will stick. Cons and Leanne, you both are brilliant. Thank you for joining us. RG, always a pleasure. Gabrielle, do you want to end it with the teaching points?
Sure. Oh my God, I'm still amazed by the case, Colleen. Such a great case. And I remember I discussed a similar case with Sabin like a month ago, and I missed the diagnosis again, but let's start with the teaching points. So first, we were discussing about fever and rash. We want to think about infection, malignancy, drugs, and autoimmune categories. We have to inquire for traveling history, the season, exposures, study also who the host. In the physical exam, we have to look the rash for the distribution pattern, characteristics, progression, and associated symptoms. Because as Ravi taught us, usually the rash is not the center of gravity in the disease, but if it is, we have to think about a skin disease, a skin primary disease such as Sweet syndrome. Then we have a non-missing infectious diagnosis to keep in mind, such as Rocky Mountain spotted fever, necrotizing fasciitis, meningococcemia, toxic shock syndrome, and endocarditis. Then we were discussing about antibiotic failure. In the CP Solvers website, we have a nice schema. We have to wonder about the wrong drug, diagnosis, thinking about if maybe this condition is autoimmune, malignancy, or a drug side effect, and also study the natural history, maybe the natural history too soon or too aggressive. Then we were connecting the dots with the vitals and notable labs and imaging. Someone in the chat mentioned about minocycline side effects. I think it was Kirtan. Some of them are hypersensitivity anxiety, drug-induced lupus, and hypersensitivity reaction. Then we were wondering about recent oral herpes bout. We have to look in the physical exam for thyroid lesions. In the physical exam, it was noticeable for pustules. So pustules plus a sexual history report arthritis, we have to wonder about disseminated gonorrhea. Pustules plus drug exposure, we were wondering about AG, that stands for acute generalized erythematous pustulosis, and usually this condition appears within 2 days of exposure. Associated drugs are tetracycline, sulfas, and terbinafine. This patient also had a gardening habit and a previous trauma report, so we were wondering about endemic fungi. And Hans said a nice phrase that is Central Valley is a coxy home. Then we were discussing about the recent upper respiratory infection episode. So we were wondering if this could be MIR, that stands for mycoplasma-induced rash and mucositis. In this condition, the ocular and genitourinary mucous involvement are common, and the oral involvement is universal. But then the biopsy showed neutrophilic dermatitis, so the final diagnosis was Sweet syndrome. And some of the causes of it, as Colleen taught us, are allopathic. Some drugs, such as trimethoprim sulfamethoxazole, thalidomide, and as in this case, minocycline, and also malignancy. And we have to treat it with steroids. So, guys, and I hope you have a great day.
Absolutely brilliant, Gabrielle. Thank you so much. Colleen, thanks again for a fantastic case. Hope to see you all tomorrow.